Howard, the other drug that we have is perhaps the most convenient, which is NEPA, which is a combination of nitupentine palonosetron in one capsule. And so that can be an oral regimen with one capsule as well as dexamethasone orally. Are you using that, and how is that working for you?
Well, the answer is yes, we do use it. About a year and a half experience with it now, with great success. It works. Our practice does have dispensing in the practice, which makes it a little bit easier from a logistic situation. The dispensing pharmacy is connected to the treatment area. So when the drug comes in and the order comes in, we have it ready for the patient. Pharmacist goes out, watches the patient take the medication, and then the line started. And by the time everything gets going, it's an hour at least. So it's an hour plus before treatment, which is good. We see the patient take it, so there's no issue. Prior to availability of the combination, we were using oral aprepitant.
Oh, you were.
And we're using the tripacks and explaining to the patient how you won't get sick by taking it. Magically, they take their drugs. We had very, very little patient failure on that end. They would take the medication and do well. When we looked at the new NK1, again, we were in a naloxone practice for 12 years at least, since I've been there. We looked at it, and efficacy among the NK1, the new NK1 drugs, are all the same, pretty much. I didn't see much of a difference. You could tease out differences depending on how you do any study, but the reality is they all worked. So efficacy in our eyes was never an issue among the choices. Safety also, similar safety profiles, little differences here and there, but pretty much all the same. So for us, it was, do we go to the more convenient step, which was using the oral across the board? And the answer was, yeah, we're going to do that. And as was mentioned, reduce chair time, because we didn't have to worry about getting the naloxone ready for a patient, which was nice. We never gave IV NK1s anyway, so that was not part of our package. But we just sort of swapped it out, and it was easy with the EMR to switch one in and one out. And it's our standard. We also have it as the backup after HEC regimens where it's built in. It's the PRN choice. So if a patient is somebody who we expect to do poorly from risk factors, or they've done poorly in past, we automatically have it built in and everything's ready to go. Some of the issues are prior auths with PO drugs are at least as difficult, in some cases more difficult. They don't want to hear it, and it's insurance companies, but it's going to cost more on the medical side, for example, to do this. But that's the medical people paying. We're the pharmacy benefit people. We don't care about what they pay. And for us, it's the overall cost. And you have to sort of filter through all that stuff and make some sense. But we try and get it for our patients. And we've been pretty successful, I'm going to say 75% of the time, getting this approved for our patients. We do use some Roeland in, strangely, insurance companies that will approve one versus the other. As strange as it sounds.
So they'll approve Palo, but not NEPA.
They'll actually
ondansetron.
They'll on the oral side. I'm saying they'll approve Verubi,
right.
And they won't approve Akynzeo.
Yeah.
They'll approve Amend, but not either of the other two, even though Amend costs more than the other two. I don't understand that.
I ran into a similar situation yesterday. My 46-year-old female, so I prescribed the nitupentine palonosetron pill. I got a call from my pharmacy, which is right underneath of us, so it's very close. And they said her plan requires a step approach. So I called the plan, and I said they wanted her to fail aprepitant or fosaprepitant and ondansetron before approving. And I said, can we go to the NCCN guideline website together and see that either option is approved? It is not a stepwise approach, and they did not budge on it. They said this is the way that we're doing. This is a managed care organization. They said this is our stepwise approach. So this person must fail on ondansetron and either aprepitant or fosaprepitant before we would approve either rolapitant or the nitupitant palonosetron.
So to be clear, that doesn't make medical sense, and it's really
We
just
went
an arbitrary
together
decision.
to the NCCN guideline
Right.
website and pulled it up, and I said, you know, these are options. There is not a one fail, this is better than at all. These are options that you have that work equally. So that was.
So the actuary made that decision, I guess, not the clinician.
Right.
It's also very much a cultural phenomenon because when you talk to Europeans or Australians, everything is oral. And when we talk about these reimbursement issues, they just laugh at us. So it's interesting that we have been such an IV focus based on reimbursement when we know the efficacy is equal.
Right, and so I think that point is they are equal, and it's changing, it sounds like, from this discussion, which is very interesting, and we're moving for a couple of dynamics, perhaps from IV to oral, but there are going to be situations where we need both. One thing we haven't talked about specifically is toxicity, incremental toxicity of NK1. So what are your thoughts on that, Dawn? And when you add it to a 5-HT3 index, what more do you get in terms of toxicity?
Right. I think what we're finding is that it really doesn't add a whole lot of additional toxicity. We're seeing a few little things, like fatigue and hiccups, but I often attribute that to the dexamethasone. So it's, we are aware that all of the NK1s have drug interactions except rolapitant, and so that we do have to make some dexamethasone adjustments, and so there might be some additional play there with the augmentation of the dexamethasone and maybe adding to some of that hiccup issue. But it's also a funny thing because hiccups can be related to nausea and vomiting. So, it all comes full circle. But I think in general we're seeing that the NK1s really don't add an incremental increase in toxicity at all.
That was our experience in the clinical trials, and that's my experience as well in the clinic. And everyone else agree with that?
Same.
Very, very little incremental toxicity, which is another reason to be more proactive using it as opposed to less, if we take cost into consideration.